Esplin. I'm a periodontist in the Boise area and looking forward to another good session with you guys. My topic today is linking the oral and systemic health. I am a periodontist, and so I'm going to be orienting a lot of my comments towards a periodontal disease specifically, just because of time restraints. We could be here all day talking about all the different oral conditions and how that relates to systemic health. But I'll be really honing in on periodontitis and how there's some links to that with systemic health, and then vice versa, how systemic health influences oral health, and kind of reviewing some considerations that way. So if we go on to the next slide. So again, even though my comments are going to be limited primarily to periodontitis, just understand that most of these oral conditions can have similar influences. So the body doesn't care if it's a bacteria from periodontitis or if it's a bacteria from a cavity. Bacteria inside the mouth cause systemic effects. And so just know there is some tie over that way. So if we move on to the next one, I want to take a second to talk a little bit more about what exactly a periodontist is. I didn't even know that a periodontist was a dental specialty until I was like a first-year dental student. I think we're one of the more well-hidden dental specialties. So my role is that I specialize in the periodontium, which is classified as the various tissues that help support a tooth in function. So that involves the gums, the gingiva, the bone of the maxilla and the mandible, the cementum, and the periodontal ligament, which attaches the bone to the cementum. So with that, we are more of a surgical specialty because most of the things that we need to treat are underneath the surface of the gums. So a few of the things I focus on treating gum disease. So that usually involves surgical debridement and bone grafting to help regenerate bone. We do gum grafting, so patients come in with recession or they have thin gums that are prone to recession or sensitivity, and we'll do gum grafting to help address those. We'll complete crown lengthening, so for patients who either need more crown surface to be able to attach a crown restoration onto it, we'll remove some bone and gum tissue to help expose more of the tooth. Or if there's patients who their tooth hasn't fully erupted and they have a gummy smile, we can help expose the tooth that's stuck underneath the bone so that way they can have a broader smile. We do frenectomies and gingivectomies. So I work a lot with orthodontists who send over kiddos who have lip ties or overgrown gums. And so we'll remove a little bit of that extra gum tissue or remove those little frenums to be able to enable better mobility of the lip and the tongue. We do a lot of work for implants. So we do extractions, we do bone grafting after an extraction, we'll place the implant, and then we also do a lot of work to prepare sites for implants. So we do bone grafting or sinus augmentation to help prepare for an implant. And we also do soft tissue biopsy. So a lot of people, and probably the most common reason why, especially in a medical setting, why people get sent over to us is usually because something really weird is going on with the gums. And so they send the patients to us, and our job is try to figure out exactly what's going on, take biopsies, and try to treat accordingly. So that's kind of a nutshell what I do. And so if we move on to the next one, I wanted to also review briefly about what exactly periodontitis is, what gum disease is. I think that being able to explain this well is something that would be really helpful in a medical setting. So I wanted to kind of show how I explain this to a patient and see if there's any little things I include that might be helpful in your setting as well. So I usually hold up my fist in my sleeve, and I'll explain that my fist is the tooth you can see in your mouth. My arm is the root of that tooth. You imagine bone that surrounds that root in 360 degrees, and then the gums are going to rest right on top of that bone. At a certain level, the bone stops and the gums attach, but then a little extra projection of gums gets laid against the tooth. It's not actually attached up there. It just kind of sits around it like a turtleneck sweater. And that leaves a small gap between your tooth and your gums. It's the same gap where popcorn husks get stuck when you eat. Well, what can happen is bacteria can get down into that little gap as well. And if it doesn't get brushed and flossed, they can form the soft white plaque, which can then calcify, and they form these deposits called calculus. You can see that there in that middle image as well, kind of that calculus forming along that root. And these are little calcifications on that root surface that bacteria actively live inside of. So not only does that calculus cause a foreign body reaction within the body, but also active bacteria are secreting toxins into that area locally. So your body senses those toxins are there. So basically they send signals to the bone saying, hey, bone, there's bacteria present, you get out of there, and it'll begin to resorb its own bone to get away from that bacteria. So that leaves now space deeper down those roots. The bacteria migrate and colonize down deeper. So then they secrete toxins there. So your body has to dissolve away more bone. Bacteria migrate further down. They secrete toxins there. And it becomes a cycle where the bacteria are slowly working their way down the root of the tooth and your body is dissolving away the bone and gums to try to get away from that bacteria. So it's actually an immune mediated process. Your body is dissolving away its own bone, more or less, is how I explain to a patient. The name of that condition is called periodontitis or gum disease. And then I do think it's appropriate to pass on, at least in my office, we pass on that diagnosis that you have periodontitis. That way they know that there is a condition that they have been assigned. If we go to the next slide as well. So the question then is for all of you in the medical setting, what exactly are you looking at? So if you were to be looking, doing a throat exam or an intraoral exam, what could you be looking for to screen for periodontitis? So some clear signs would be calculus and plaque buildup. So again, that white fuzzy plaque and then hard white plaque that also might have calcified around the teeth. That could be a sign that there is a contributing factor to periodontitis. Inflamed gingiva, tooth mobility, frequent and easy bleeding of the gums on manipulation. Sometimes you can even see suppuration or pus on the gingival margins, and halitosis. Of course, the way that you have to properly diagnose it is with a periodontal exam where we take measurements of the pockets using a periodontal probe. But I think if you see a patient who comes in looking like this patient here, where you can appreciate that there's a lot of bone and gum loss around these teeth. These teeth are extremely mobile in this patient. And you have this heavy buildup of plaque and inflammation. It'd be safe to say this patient has a high chance of being diagnosed with periodontitis. What's really important, though, is that this is a painless condition. Periodontitis is almost always painless. The only time that patients are going to have pain is either in the advanced stages of the disease, where there's only a little bit of ligament holding in those teeth. In that case, they're going to be chewing on just a little bit of that ligament. And so those ligaments can get sore. And so what that'll look like is a patient will say, yeah, my teeth get sore. Sometimes it's sore over here for a little while, then it goes away. And then it's sore over here and it goes away. That's usually a sign that they are in advanced stages of periodontitis. But again, normally it is asymptomatic. The other time you may experience pain is if a patient develops what's called a periodontal abscess. And that's where if the bacteria have gotten deep enough down the root that in your body trying to fight that bacteria, the byproducts build up deep in that sulcus. And so there's nowhere for it to express. And so then you'll have a buildup of pus along the gum line. So in those cases, the patient will say it hurts right here. They'll usually be able to target it, and it hurts consistently. Like it's hurt right here for a week. That's usually a sign that if you look intraorally as well, you'll see a big red spot with usually a little bit of pus associated with it. And if you touch the area, it should exude some more pus as well. And that'd be a sign there's a periodontal abscess present. And that's more of an acute dental emergency, more so than a chronic condition like periodontitis. So I'd say inside of your patient's mouth, you ask them, is it painful? If the answer is no and they look like this, they likely have mild to moderate periodontitis. If it is painful, they likely are either an advanced periodontitis, if it's diffuse, or if it's more acute and more in one spot, then they likely have a periodontal abscess. Okay, if we go on to the next slide. It's really common. So 47% of the US population have periodontitis of some degree, especially in individuals who are over the age of 65. So 64% of adults over the age of 65 are going to have periodontitis to some degree. The main risk factors I'm looking at, poor oral hygiene is probably the most common. Patients just don't take care of their teeth. They're letting the bacteria get down underneath the sulcus. And so they're going to be developing those calculus deposits that are contributing to periodontitis. Two other really common ones, though, is smoking and diabetes. Those are kind of the main three. There's a lot of other satellite things that could contribute to it, things like genetics or their ethnicity, but we're thinking mostly poor oral hygiene, smoking, and diabetes being the reason why patients get periodontitis. All right, if we go on to the next. The treatment for periodontal disease is going to be that we need to remove the bacteria on that root surface. Sometimes it is calcified calculus, sometimes it's plaque, sometimes it's just bacteria living down that area. And that requires physical debridement. So this is a tooth that I extracted not too long ago. You can appreciate how big those calcified deposits of bacteria can get on those roots. And the only answer is that we need to physically debride that off. Antibiotics usually have a very limited response. The only exception to that would be if they have a periodontal abscess. Sometimes antibiotics will help reduce their symptoms, but it's not going to treat the condition. We have to physically debride the root surface to remove it. And the two common ways that happens is either with surgical or non-surgical therapy. If we go on to the next one here. So what that non-surgical therapy looks like, it's commonly called scaling and root planing. What that looks like is this is typically done by a hygienist. So typically even a general dentist's office, scaling and root planing can happen with their hygiene team. This is where the gums remain in place and they use specialized curettes and other instruments to get down in between the gums and that root surface to clean off all those deposits of plaque and calculus to try to get the bacteria, the local factors out of there. This is a really good treatment for patients who have had limited dental care in the past and likely have just a lot of plaque and calculus. You'll usually see a really profound healing response in those patients. This is also a fairly cheap route, especially if you go through a general dentist office, because you can do it with a hygienist. The downside, though, is they do have limited access to these deep pockets. So a lot of the research shows that they can get about 5 millimeters down these root surfaces to get everything cleaned out. But advanced periodontitis, they can come in with 7 to 15 millimeter pockets. So they'll really clean the top 5 millimeters really well, but not really get down deeper. Then they have to do it by feel as well. They work kind of blindly. The analogy I always use is, I don't know if you've ever tried to plug into an outlet that's behind a couch or behind your bed or something like that, and you're trying to stick your fingers up there and try to feel, okay, where's the two lines, where's the little dot, and you feel your plug. Okay, there's the two lines. Trying to do it all by feel. It's usually pretty challenging to get the right orientation, and that's more or less what a hygienist is having to do. Is they're trying to feel up there and try to see what's in that area. If we go on to the next one, the alternative to non-surgical therapy is surgical therapy, and that's typically done by a periodontist. So my role is that I reflect the gingiva out of the way so I can see that root surface directly. So my role is to pull the couch a few inches away from the wall so I can just see the plug and just plug in into the outlet more or less. Not only does that give me a chance to really clean that root surface well, but I can also modify the way the bone looks around the tooth. I can apply antibiotics locally onto the root surface, and then I can also place bone grafting material. So this is the case I treated last week, where you can appreciate how much bone this individual had lost around their front tooth. But then I was able to get that bone graft in place. And they've done histologic studies afterwards that show that this will regenerate the periodontium to some degree. We can't get it all the way back. I tell you, we can't get the gums back to where you were when you were 20. But if I can get you back 3 or 4 more millimeters of bone, that's going to buy you 7 more years with that tooth. And so provides an opportunity for more reversal of the damage, more than just kind of mitigating it. The downside is this is a more expensive approach to treatment because we are involving regenerative materials and things like that. So in a patient with advanced periodontitis who we know need a bit more access, this would be surgical therapy would be a consideration. All right, if we go on to the next one here. So that's kind of your 3 years of periodontal residency in 15 minutes there. But now I want to talk a little bit more about kind of that connection to systemic health. So this is the new patient intake form that we have in our office, kind of taking tabs on kind of the systemic conditions that these patients have. I've never seen or heard of a patient where if they were provided an opportunity to do a medical history that they would check other and write down they've been diagnosed with periodontal disease, which is kind of interesting because, again, almost 50% of the US population has it. I'm sure there's probably a smaller percentage of them that have actually been diagnosed. But I think a lot of times it's why, the reason why is that people divorce what's happening inside their mouth and conditions they've been diagnosed with systemic health. And if they were being checked for their systemic health, rarely would they mention an oral condition. But they're intimately linked. I mean, the mouth is a part of the body. It's the first part of the GI tract, and there's links that can happen that way. And then I also pose it this way: is if I were to ask you all rhetorically, if you were to have a patient come in and say your patient at 2 o'clock today is a new patient, they've checked on their medical history that they have periodontal disease. Are there any conditions that immediately come to your mind that you might want to pay additional attention to of the possibility of them having those conditions or other things that might be linked to that? So kind of the purpose of the rest of my discussion here is to kind of review those links that might be associated with periodontal disease and likewise other oral conditions. To put it slightly differently, if you go to the next page here, if I were to ask you all, where on your body would it be okay if you bled if you touched it? If you had a patient, again, your 2 o'clock patient comes in, they say, yeah, I've got this spot on my arm that I can't wash it because if I touch it, it starts bleeding spontaneously. I'm sure that would raise a red flag. But unfortunately, that's the case for so many people inside their mouth on the periodontium is if they touch it, it starts bleeding. But for some reason, that's become almost acceptable that bleeding gums doesn't need necessarily intervention. Think of it another way. The surface area of the periodontium is about 11 square inches. If a patient has gingivitis, so the gums are just inflamed, not really showing bone loss, the wound surface area would be about 1.5 to 3 square inches. If a patient has periodontitis, where that wound area is now kind of creeping down and around the roots, that wound area is about 4.6 to 6 square inches. For reference, that's about the surface area of a ping pong ball. So again, if you imagine, again, your 2 o'clock patient saying, I've got this ping pong ball sized lesion on my foot that bleeds when I touch it. And it's been like that for 5 years. So I just don't really interact with that area of my body anymore. Again, that would be some red flags. But that's what a patient with periodontitis is having inside their mouth. And you think about the way your body is responding to that constant threat and that constant interaction with bacteria in this open wound, and how that might affect the rest of the body and regulate the pro-inflammatory cytokines and things like that. So keep that in mind as we go into these next body conditions. So if we go on to the next one, I like to start with diabetes. As I mentioned, this is the most common systemic condition that is linked to periodontitis. And I think it's important to know that there is a really intimate link between the two of them. So if we go on to the next one here, a quick thing about periodontists, we are definitely the nerds of the dental community. We spend a lot of time really deep into the literature. I know in residency, we would do oral exams, and with every sentence, if we had made a claim, we had to have a study memorized to back up what we said. So I've tried to do the same thing as those was an oral exam for me here. So I'm not going to make a claim unless I have a study to back it up. And I've attached those citations as we move through here. And I believe the slides are also available. So if you ever wanted to read into these studies, I'll have those available for you. So first of all, so patients with diabetes, are they at higher risk of developing periodontitis? And the answer is yes. And that's very, very well established. So they did a study first looking at some diabetic children. These are patients with diabetes type 1, so type 1 diabetics. And they found that the odds ratio of them developing periodontitis over the course of their life was 20. So very, very high likelihood. And then when they looked at some patients where looked at the degree of their glycemic control, they found that poorly controlled diabetics were 2 times more likely to have severe periodontitis in one study and had a relative risk of 11 compared to non-diabetic controls in another study. So it is related to poorly controlled diabetes. So if you have a patient who comes in and they have a relatively well-controlled A1C, they only have a slightly higher risk of developing periodontitis compared to the normal population. But if they're poorly controlled, their risk is very high. If we go to the next slide, looking at the reverse one, then, if a patient has periodontitis, are they at a higher risk of diabetes? So for my patients I see on a regular basis, are they at higher risk of diabetes? And the answer there is also yes. So they did a correlatory study where they looked at how their degree of periodontitis and what their HbA1c was. And this is a large population that they did this on. And they found that patients, the more severe their periodontitis was, the higher their mean HbA1c was. And then the question is, well, why is that a case? Or what's really the interaction there? If you go to the next slide, periodontitis increases the systemic inflammation inside the body. And we'll talk more about that. That's going to be a constant theme. If there's any takeaway that I would want you to walk away with about the link between systemic health and periodontitis, it's that patients with oral inflammation will have increased inflammation throughout their body. And that affects everything. And I know you all know as healthcare providers that inflammation is kind of the bane of your existence. We're trying to control conditions of inflammation. And so for patients, and when it comes to diabetes, the periodontitis is increasing their systemic inflammation, and that is lowering their insulin sensitivity. And then looking at the other way around, diabetes increases the accumulation of what's called advanced glycogenated end products in the end organs, and the periodontium is considered an end organ. And so those glycogenated end products help decrease the blood flow and decrease the collagen turnaround in the periodontium, which increases the way that destruction happens. It also upregulates what's called the Rankel OPG ratio, which increases that bone destruction around the teeth. So then the question that can come up commonly is, if you were to treat periodontitis, could you positively affect your diabetic's patient glycemic control? And if we go to the next slide, the answer to that one is maybe. There's a lot of studies that say yes, a lot of studies that say maybe, a few studies that say no. But I think that the research that's been done that has a yes to that answer is really compelling. This first study, I'm going to be citing this study a lot, but if you treat periodontitis, you show a decrease in systemic pro-inflammatory cytokines. That includes CRP, TNF alpha, interleukin 6, fibrinogen, some prostaglandins. So if you can get the inflammation down in the mouth, you will decrease the inflammation throughout the body. And that influences the HbA1c. So one case study showed that by doing periodontal therapy, you reduce their HbA1c by 10% in one study and 17% in another. And then in these really big meta-analyses, they showed that having that periodontal therapy decreased their HbA1c by 0.36 to 0.65, somewhere in that range. The common way that we will say it, and the kind of the conclusion with all these studies has been that treating periodontitis has a similar effect on the HbA1c as adding a second medication that manages periodontitis. So same as if you had a patient with metformin, you decide you want to add on another medication to help them get better glycemic control, imagining the difference in their HbA1c that you would expect. That's more or less the benefit you would see in having a patient who has not been treated by periodontitis to receive that care. All right, if we go to the next slide now. So now switching gears, we're now going to talk about cardiovascular disease. And so going over again. So they've done a few studies and they show that patients with periodontitis have an odds ratio of about 2.2 for developing some form of coronary heart disease. And then also looking at some prospective studies, they found that periodontitis patients had about a 1.14 higher risk of coronary heart disease. And then in a really interesting set of studies, they looked at atheromas that were dissected out of patients, and they looked at what type of bacteria were in them. And in 44% of those atheromas, they actually found periodontal pathogens. So the bugs that were found in the bottom of these pockets in patients with periodontitis, they would find them inside of these atheromas. And so if you go to the next slide, the question is how in the world does that happen? So again, we're going back to those increased systemic pro-inflammatory cytokines like fibrinogen, CRP, interleukin-6. Those are all upregulated in patients with periodontitis and tgoing to increases their risk of cardiovascular disease. Also, whenever you eat, so all of you might be sneaking a bite to eat right now, or maybe after this call is over, you're going to be eating anytime you brush your teeth, anytime you chew gum, you do induce bacteremia to some degree. So the bacteria that are inside your mouth do get inside of your blood vessels. Also in patients who have periodontitis, they have a lot of endotoxins in those sulcus, and those get into the bloodstream as well. And also in those patients with gum disease, the bacteria tends to be a bit more pathogenic. So they can cause a bit more damage. They're the gram-negative anaerobic bacteria. And so those get going through the bloodstream, and those can actually damage some of the endothelial cells and can alter the endothelial and platelet function. And so they've actually shown that in some studies where they show that the endothelial-mediated vasodilation is inhibited in patients with periodontitis, and it can contribute to the formation of those atheromas. So if we go to the next slide here. So then if you were to treat periodontitis, can you lower the risk of cardiovascular disease? And the answer to that is yes. So again, going back to this TU study, treating periodontitis decreases pro-inflammatory cytokines. And then also they show that by treating periodontitis, you improve their endothelial cell function. And they show that using brachial artery vasodilation. And then in some interventional studies, they show that treating periodontitis may reduce blood pressure by 12 points systolic and then 10 points diastolic. So we can see benefits. And this is actually, we see a fair number of patients who refer to us from cardiology or cardiovascular surgeons wanting to make sure that everything is sound with the periodontium before doing treatment for that reason, because they don't want to have these really dangerous bugs going into their surgical site. Okay, let's go on to the next slide. We're going to shift gears again and talk about pregnancy. Move on to the next one here. So a few definitions. So preterm infant is defined as, in these studies, as a baby who's born with fewer than 37 completed gestational weeks, and low birth weight is less than 5 pounds and 8 ounces. There was a study done by Offenbacher where they adjusted for all the known causes of why someone might have spontaneous preterm birth and wanted to look specifically at just periodontitis. And they showed that patients with untreated periodontitis had an increased risk of up to 7.9 times to have a preterm low birth rate baby. And then also when they did blood tests to look and see if these pregnant women had an antibody to P. gingivalis, which is one of the most dangerous pro-inflammatory periodontal pathogens, they found that they were 4 times more likely to deliver a low weight baby. And going to the next slide about why that might be the case. So those gram-negative anaerobes and then the endotoxins that are inside the mouth, and as those get inside the bloodstream, that increases inflammatory mediators. And one of the main ones that's relative to birth is prostaglandin, which we know plays a role in ripening the cervix and preparing things for birth. So if we have increased systemic prostaglandins from periodontitis, then the cervix may be ready too early and end up with a preterm low birth rate baby. If we go to the next slide. So then if you were to treat periodontitis, can you lower the risk of a preterm low birth rate baby? And the answer to that is also yes. I want to do a little caveat here that periodontal therapy is generally safe during pregnancy. We try to avoid anything that's elective during pregnancy, especially for first and third term. But for something like this, if a patient comes in who's pregnant and they are realizing they might have periodontitis or they're having a lot of gum inflammation, we feel very comfortable treating those patients because we know the benefit it has not only to the mother, but also to the baby. And so I think that this would be something that I wish would happen more often in OBGYN offices, in places where we're doing screenings with pregnant women, that taking a look at the gums and seeing if there's signs of that gingival inflammation, or asking even the simple question of just how often are you having your teeth cleaned right now? And if they're pregnant and said, I haven't been to the dentist in 5 years and the gums are inflamed, I would love to see those pregnant women in a dental office more often. Because if you look at this next study here done by Lopez, this was a study out of Brazil where they looked at hundreds of pregnant women who they identified had periodontitis. And they grouped them into some where they treated the periodontitis before they gave birth, and others where they said, well, treat this after you give birth. And the patients where they treated the periodontitis before they gave birth had a preterm low birth rate of 1.8%, versus the women who waited until after pregnancy had a preterm low birth rate of 10%. So a significant increase for those patients who had periodontitis. So it's something that'd be worth screening for and checking out for. All right. Next up, we have just a brief little speed round. Again, I know I'm trying to keep everything to about 30 minutes. So we have time for questions and for the case study. When we were in residency learning about this lecture about systemic oral health connection, it was like a 6-hour long gauntlet that we looked forward to having every year. And so I'm trying to give you all the highlights here as much as possible. But 3 more I just wanted to hit on briefly. So first is osteoporosis. So they show that women with osteoporosis had 5% more loss of attachment around their teeth compared to women who did not have osteoporosis. And then in a longitudinal study done in Japan, looking at men and women, they show that people who had osteopenia were more prone to developing deeper pocketing over the last 3 years. So the link between patients who have periodontitis being more at risk of developing osteoporosis isn't as well established. But if you have a patient with osteoporosis, they are at higher risk of having periodontal disease. With erectile dysfunction, they show that patients who had erectile dysfunction had a prevalence of periodontitis at about 27% versus 10% in patients without erectile dysfunction. Again, that's related to blood flow and altered blood flow that can be associated with periodontitis. And then Alzheimer's disease has been getting a lot of attention in the literature over the last 10 to 20 years. And they're starting to show this really strong link between patients who've had a history of periodontitis and increased risk of developing Alzheimer's disease and otherwise cognitive decline. The study done in 2022 showed an odds ratio about 1.67 for patients who have periodontitis developing Alzheimer's disease. There's lots of other links. So obesity is one. We know that fat tissue acts as an endocrine organ that secretes more of those pro-inflammatory mediators that help increase the inflammation inside the periodontium. So patients who are obese are at a higher risk of periodontal disease. Really well-established links to rheumatoid arthritis, GI disorders like Crohn's and ulcerative colitis, and then also a few links to a higher risk of cancer. But if we go to my final slide here, the real main takeaway is that, again, it all comes back to that systemic inflammation. So the patients who we see coming in with periodontitis have stores of bacteria deep within their gums that are secreting these toxins and these endotoxins and other factors that are upregulating the body's inflammatory response. And those pro-inflammatory mediators circulate through the body and can affect most body systems. So as a periodontist, my hope and my dream is that, I think there's room for improvement on both sides of the fence, of course. But as healthcare providers, I think just looking inside, if I were to ask one thing I would hope for is just as a healthcare provider looks inside the mouth, which you do during your routine exams, just glancing at the gums and see if there are those signs of oral inflammation like we saw in that original slide. So red gum margins, the presence of plaque and calculus. If you were to tap on a few teeth with your tongue depressor to see if anything might be loose, that bad breath, asking the patient if it hurts to chew, any of those signs that they might have active periodontitis, and then identifying that early, not only is that going to help patients preserve their dentition, because obviously periodontitis is catastrophic to the mouth, but also that might help you in your efforts to try to mitigate some of those systemic diseases. Going back to the effect of it on the mouth, I would say the most common reason why patients end up in dentures is because they've had periodontal disease at some point. So if we can identify these conditions early, if you help patients, encourage them to get into a dentist and have that treated, that might help them keep their teeth as well, benefit systemically. And I also think there's definitely room for that with dental providers as well. We look inside the mouth and we see the periodontal disease. but oftentimes skip over for whatever reason, asking the question of, have you seen your physician lately? Would you know what your last A1C was? Um, Being aware of that, I mean, I've been able to help several patients identify they have undiagnosed diabetes because of the way things look inside their mouth. Helping patients identify cancers because of things that look inside their mouth. So I think there's room for both of us to be mindful of what we treat and how we can help get each other to get patients to the right place. And again, early treatment of that periodontitis and then the surgical therapy in those advanced cases is key in an effective management of oral disease. If we move on to the next one here, I wanted to provide my contact information as well. I know that was a feedback that we received after the first session is wondering who you can reach out to. You're more than welcome to contact me. This is my personal cell, my personal email. If you have a patient that you're scratching your head over or something looks funny, you're more than welcome to reach out to me. I do work in a group practice with two other periodontists. So if you have PHI you want to send over, a picture or something like that, and you're not hearing from me, you're more than welcome to give the office a call or shoot us an email, and someone will be in touch with you as soon as possible. So feel free to say that, reach out anytime if I can help.
Thank you. So we do have a question in the chat for our panel. How important is it to have a mouth check before joint replacement or cancer treatment?
It's important. Is that too simplistic of an answer?
Love it, but I would like more detail. Thank you.
Well, I think it sort of ties along with, the whole premise of this whole series, right? That there's a connection between the mouth and the rest of the body. So knowing that they're going in for a fairly invasive procedure, whether it's, ongoing cancer treatment or medical treatment or some sort of surgery, I think doing the best to ensure that every part of their body is as healthy as possible, whether it's their mouth, their diet, they're getting, adequate nutrition and rest. So along those lines, I think it's pretty important that they do get some sort of oral check, dental check to make sure that there isn't some active infection. Because kind of like, Casey was saying earlier, many of the germs and bacteria that are in the mouth can show up in other places. So I think reducing that number in this part of the body can certainly help with in other parts. So that's, I guess, a layman's answer, hopefully a reasonable approach. There's a lot more specifics in research, and I'll leave that to smarter people on here to go on to that.
Thank you, Ernest. Did anyone else want to add? Erica, go ahead.
Yeah, and I think probably Dr. Esplin can elaborate more on this, but two things to think about. One, the bacterial load, like Dr. Ernest was explaining. There is a lot of consequences in the mouth from cancer treatment. Many times patients have dry mouth from either radiation or chemotherapy. And so that's going to put our mouth at a higher risk. So starting with a healthy mouth before going into cancer treatment gets you a step ahead. And then having that connection with your dentist, that education, being prepared to how to take care of your mouth once you are receiving cancer treatment is very helpful. So working preemptively in that end. And on the joint replacement part, besides, like Dr. Mishakar said, having that bacterial load lessen before surgery, there has been studies, and I leave that up to you, Dr. Esplin, that show bacteria from gum disease invading artificial joints. I don't know how advanced those studies or how much proof there is of that, but I've seen some of those as well. So it's a risk to have active periodontal disease and then risking of failing an artificial joint because of bacterial infection.
And just to add to that as well, so it's absolutely true. And in fact, there was a joint statement between the American Dental Association and the American Academy of Orthopedic Surgeons, where they recommended not only to have things treated beforehand, but also that from then on, basically for the rest of their life, they needed antibiotic prophylaxis before having dental treatment. I do think it's important that I think in 2022, they have revised their stance there, saying that if patients have had a long-standing joint replacement, that antibiotic prophylaxis wasn't necessarily recommended anymore. I bring that up because that's I don't get a chance to talk to healthcare providers very often, and I wish I could talk to orthopedic surgeons a bit more often. I think a lot of them, because of tradition or because of habit, just that if a patient has orthopedic joint, they need to have 2 grams of amoxicillin before cleaning every single time. But the stance now in the literature is showing that that risk for long-standing joint replacement is not supportive of having an antibiotic prophylaxis anymore. But I absolutely would agree for preparatory to a joint replacement and making things as clean as possible. And then maybe considering for the first few months, there's a few studies that say there is a little bit of higher risk, but that isn't really well supported in a lot of those literatures as well. But for long term, I don't think we need to be giving quite as much antibiotic for patients with joint replacement.
Okay, great. Thank you. Also, I did forget to mention one thing for anyone who is interested in sharing a case in the future. We do write up the recommendations for you and send them out afterwards. So, another perk for you if you're interested. Okay, so there's another question in the chat. Are there any probiotics that are healthy for the mouth? Who wants to start?
I think this is sorry, Casey, were you wanting
Oh
to
no,
say
it's all you.
something? Oh, I was just going to say this is probably an evolving and developing area, it feels like, in dentistry. First of all, the short answer is yes. Probiotics can be a helpful, I would say, adjunct for oral health. Um, and I would say pick your favorite brand. I mean, there's different, just make sure it's one, that has an adequate number of live cultures. And, even if you can't do that, sometimes I will have patients just make sure they're taking yogurt. Yogurt, like Greek yogurt will have, live cultures in there. If you can get the sugar-free version, even better, because, you don't want to kind of have a bunch. Some of the yogurts just have way too much sugar. But I would say I don't know. Maybe others might have specific brands or ones they lean towards. But yes, definitely using some sort of probiotic can be helpful for the mouth.
Casey, did you want to add to that?
No, I absolutely agree. Though, in terms of periodontal disease, they've done some studies looking to see how preventative that is, and that also includes supplements. So I get asked often, like, if I take a vitamin B supplement, does that help protect against it? If I take omegas, does that help prevent against it? And the two that I'm aware of is that taking omegas and also a probiotic can have a moderate or a modest protective effect against periodontal disease, but it's not something that would, again, I don't think it would keep Dr. X patient from having periodontitis. But for the average person, having a probiotic of some kind can help prevent gingival inflammation, and same with the omegas. With that, though, I kind of lost my train of thought there. But it is moderate. I don't think it's worth going way out of the way to try to get that there. Oh, there are some out there though that they try to take advantage of that literature, and there are some very, very expensive probiotics that are marketed as a dental probiotic. I had a patient come in saying that she showed me these supplements that she was paying like $300 for a bottle every month for these that's supposed to help cure her periodontal disease. And I try to very gently remind her that I think she might be taking the cleaners a little bit, and that even if it was really protective, I don't think it would do any more than the capsules that you would be able to get at Walmart. So beneficial, but nothing to break the bank over.